Hello and welcome everyone. I'm continuing with the renal pathology and the topic is membranoproliferative glomerulonephritis. It is also known as mesangial-proliferative glomerulonephritis, and in this there is basically immune mediated glomerular injury, and this is not a single disease entity. There are various causes which can lead to Mpgn, and in all those diseases, when Mpgn is manifested, it will have some common features like alteration in the basement membrane, which I will discuss in detail later, then increase in the mesangial matrix, then proliferation of the cells of the glomeruli, and there will be proliferation of the mesangial cells, proliferation of the capillaries, and then leukocytic infiltration, because whenever there is immune mediated injury, there will be infiltration by the leukocytes, and then they will cause the damage to the glomeruli. And then there will be deposits which are seen in the mesangial glomerular capillary wall, and the deposits can be subendothelial, membranous, and the Mpgn, it was traditionally classified based on the location of these deposits. So traditionally it was called like type 1, type 2, type 3, but presently they are divided on the basis of the etiology. So earlier the Mpgn type 1, it is basically immune complex mediated disease. So here immune complexes are made, either they are circulating in the circulation and they reach the kidney, or the planted antigens in the kidney and antibodies come and attach to them, and there is deposition of the immune complexes, and these immune complexes, they are made up of immunoglobulins and complement. These immune complexes, they cause the activation of the classical and alternate pathways, and Mpgn type, it can have a variable causes. And second is Mpgn type 2. Earlier it was called Mpgn type 2, and presently it is called dense deposit disease. Another name is the C3 glomerulopathies, and the diseases that come under C3 glomerulopathies are dense deposit disease and C3 glomerulonephritis. So in the dense deposit disease, it is called so because there are electron dense deposits which are seen in the basement membrane, and these are very electron dense and their composition is unknown. So still the research is undergoing to find out the nature of these deposits. And the causative, the etiology is there is dysfunction of the alternate pathway of the complement system. So there is this is the most important mechanism, which is activation of the alternate pathway of complement, and this is seen in Mpgn type 2, also known as dense deposit disease, and these C3 glomerulopathies, they are also seen in this. And then there is Mpgn type 3. Again, the etiology is not much known, and the research is underway, and in this there is subendothelial and subepithelial deposits, and some C3 glomerulopathies, they also come under Mpgn type 3. Now we come to the etiology of Mpgn. So one is when the cause is not known, and it is known as idiopathic or primary, and it is, we label Mpgn as idiopathic when we have ruled out all the secondary causes. And Mpgn, the primary Mpgn, it can be type 1 or type 2, while secondary is invariably type 1. And the causes of secondary Mpgn can be autoimmune diseases like SLE, then infections, very important, hepatitis B, hepatitis C. The MCQs come on these causes, then endocarditis, chronic visceral abscesses, HIV infection, schistosomiasis, toxoplasmosis, again MCQ come on this toxoplasmosis. Then other causes can be cryoglobulinemia, paraproteinemias, alpha-1 antitrypsin deficiencies, and malignancies like chronic lymphocytic leukemia. So these are the important causes of secondary Mpgn, and when all these causes are ruled out and they are not found, then we label it as primary Mpgn. So you should remember these causes. Now clinically, the Mpgn presents as nephrotic syndrome, and sometimes hematuria is also associated. So it has got a mixed nephrotic and nephritic picture. So the proteinuria is generally non-nephrotic range, although when the disease becomes progressive it can be of nephrotic range, and along with that you can see hematuria. So a combined nephrotic and nephritic picture can be seen. The disease it is seen in children as well as adults, and it is slowly or rapidly progressive, and it progresses to chronic renal failure in about 50% of the patients within 10 years. Now, in the pathogenesis, we know already have uploaded lecture previously, and you can refer to that, how the immune complexes they cause the glomerulonephritis. So immune complexes, when they get deposited, they cause the complement activation in Mpgn type 1, and the source of antigens, these are the various infections. It can be this source of antigens, and these complexes when they are present within the glomeruli, they will cause the inflammatory process, and there will be leukocytic infiltration and release of various enzymes and chemical mediators which will cause the damage to the glomeruli. So this is what will happen in the Mpgn type 1, which is immune complex mediated glomerulonephritis. So what will be the morphology? In Mpgn, the glomeruli, they are large, hypercellular, cellularity is increased because the mesangial matrix is increasing, the mesangial cells they increase in number, there is enterocapillary proliferation as well as leukocytic infiltration, and because of this the glomeruli, it has got a lobular appearance. This you should remember. Then in the glomerular basement membrane, in Mpgn type 1, when there is immune complex deposition in the subendothelium, so in that when there is deposition of the immune complexes in the subendothelial region, there is duplication of the basement membrane. Also there is interposition of the mesangial cells within the basement membrane, and this leads to the tram track appearance of the basement membrane, and it can be demonstrated with the stains like the PAS stain. So that will highlight the tram track appearance, and it is also known as splitting of the globular basement membranes. This figure again from the Robbins. So they have used a silver stain to highlight the basement membrane, and you can see that there is this splitting is there. So splitting in the basement membrane, and this is because of two reasons: because of the duplication, the basement membrane laying down of more basement membrane material around these deposits, and secondly because of the interposition of the mesangial cells in the basement membrane. Again in the morphology you see this picture, it has got a lobular appearance. This is the glomerulus, and this is showing increased proliferation of cells, mesangial cells, they are increased, and the matrix is also increased, and it has got this lobular appearance. And this is a diagrammatic representation from the Robbins. And see, in type 1, these are the mesangial cells, this is the fenestrated endothelium, and the deposits are present in the subendothelial location, that is between the capillaries and the basement membrane. So these are the deposits, and these mesangial cells will sometimes interpose in the within the basement membrane, and that will cause this appearance of tram track. Next, findings of electron microscopy. So electron microscopy will show the electron dense deposits which are subendothelial in location. So you remember in Mpgn 1 the deposits are subendothelial, and these deposits are made up of IgG and C3. So immunoglobulin and C3, because these are immune complex deposits, and this will be illustrated by the immunofluorescence. And sometimes the deposits can be mesangial also. Occasional deposits can be seen in the mesangium and occasionally can be seen in subepithelium, but majorly they will be in the subendothelial location, and along with C3, C1q and C4 can also be present there because of the activation of the classical pathway of complement system. Now see, this is again the same diagram. These are the visceral epithelial podocytes, then these are the this is the basement membrane, and these are the deposits which are subendothelial. And mesangial cells, they also sometimes interpose between the glomerular basement membrane in adjacent to the deposits, so that causes the tram track appearance. So mesangial interposition is there. Now again the same picture, the tram track appearance, and this is the picture I have taken from this site, and it is showing the how the mesangial, this is a normal where there is the podocytes and the capillary endothelium. These are the mesangial cells. Here the mesangial cells, they are it is showing the interposition of the mesangial cells in the subendothelial and basement membrane locations. So this causes the tram track appearance. So you should remember this. Important for the MCQs. Now lastly, the dense deposit disease. Earlier it was called type 2 Mpgn because earlier it was based on the presence of these electron dense deposits in the glomerular basement membrane, and now we define it on the basis of the Ethiopathogenesis. So Ethiopathogenesis is there is excessive activation of the alternate complement pathway, and some diseases which come under type 2 Mpgn, they are also known as C3 glomerulopathies, and dense deposit disease and C3 glomerulonephritis, both they come under this. And in this there is excessive activation and dysfunction of the alternate pathway because of circulating antibody which is called C3 nephritic factor. This C3 nephritic factor, it stabilizes C3 convertase, and it prevents the inactivation of C3 convertase, and because of this there is increased breakdown of C3 to C3a and C3b. This will lead to hypocomplementemia, and this is important feature of dense deposit disease. So the deposits in the basement membrane, they are the dense deposits. The nature of the dense deposits is unknown. The composition of these dense deposits is unknown, and on either side of the dense deposits there is deposit of the C3 without any deposition of IgG. So this is again important from the MCQ and the theory point of view, that the deposits in the glomerular basement membrane, the dense deposits, their composition is unknown, and on either side there is C3 complement deposition. Now these C3 deposits, they can also be seen in the mesangium, and the round circular deposits, they are seen in the mesangium, and they are known as mesangial rings. So these are about the deposits which will be seen microscopically. They can be mesangial proliferation or inflammation will be seen. Then sometimes crescent can also be seen, and dense deposits in the glomerular basement membrane can also be appreciated in the light microscopy. Again, electron microscopy, these ribbon-like dense deposits of unknown composition are seen. Then in immunofluorescence, we can detect that these are C3, their nature is C3, and they will be seen on either side of the dense deposit and also in the mesangium in the form of mesangial rings. So these are the very important points in the dense deposit disease. So other complement mediated disease in which there is dysfunction of the alternate pathway is C3 glomerulonephritis, but it lacks the dense deposit, so that's why we don't put it under the dense deposit disease. So here again the mesangial proliferation is there and capillary wall is involved. There's a diagram, and in this you can see these immune deposits, they are composed of C3, and these are known as mesangial rings. Now again the same diagram of Robbins, and in this again we see in the type 2 or dense deposit disease, these are the dense deposits in the glomerular basement membrane, and on either side of this there will be C3 deposition. Again, this is the dense deposit disease with the electron dense deposits seen in the glomerular basement membrane. So these are all the important points which you should remember. Clinically seen in children and young adults, so can be present as nephrotic syndrome, or along with it hematuria can be seen. Again, it has poor prognosis, and recurrence after renal transplant is common, and more than half of them they progress to end stage renal disease. Now, what investigation will you do to diagnose it? So we can do, after the clinical examination and history, we proceed with the blood test, where we can see for azotemia. So burn creatinine you can order, then urine examination for proteinuria, hematuria, then renal biopsy. In renal biopsy, you see the light microscopic changes. Then you can also use the material of renal biopsy for electron microscopy and immunofluorescence studies. So that way we can make the diagnosis of Mpgn. So lastly, the summary. Mpgn, membranoproliferative glomerulonephritis, or mesangiocapillary glomerulonephritis, it can be primary, idiopathic, or secondary due to various reasons. There can be various infections, neoplasm, and paraproteinemias, cryoglobulinemias, and the primary one, it can be type 1 or type 2, while the secondary one is mostly it is type 1. So type 1 is immune complex mediated, and there is activation of both classical and alternate pathway. More importantly, the classical pathway is activated. Then there is deposits, and the location is subendothelial. This is to be remembered. And then there is tram track appearance of the glomerular basement membrane. The splitting is there. Reason? Because of basement membrane deposition and the mesangial interposition. Then immunofluorescence, the deposits, they are made up of C3 and immunoglobulins. Sometimes C1q and C4 can be seen, but you should remember this. Then in type 2, known as dense deposit disease, there is dysfunction of the alternate pathway. Alternate pathway activation is seen. Then there will be electron dense deposits in the glomerular basement membrane, and on either side of those deposits there are C3 deposits which are granular, and there is no immunoglobulin in those deposits. This again you have to remember. And there is C3 nephritic factor which is circulating in the plasma of that patient. So this is all the important points of Mpgn which I have tried to cover, and any question they are most welcome in the comment section. And next topic will be IgA nephropathy. Thank you very much.